This is Dr. Gary Heller and Stephen Horgan from Morristown Medical Center, Morristown, New Jersey. Morristown Medical Center began the PET program approximately a year ago, and this is a case from the clinical practice. I will ask Dr. Horgan to describe the case and the findings of the cardiac PET perfusion study that was performed. Dr. Horgan?
Thank you, Dr. Heller. So this is the case of a 76-year-old woman experiencing exertional dyspnea. She has multiple cardiovascular risk factors, including hypertension, diabetes, dyslipidemia, positive family history, and she is a former smoker. So she's somebody who actually has osteoarthritis, and the ordering cardiologist felt that she was not a suitable candidate for exercise, and in the knowledge of our PET program, opted for PET due to the better sensitivity and specificity when compared to PET, or when compared to SPECT. So she came and underwent a standard vasodilator rest stress PET-CT myocardial perfusion study. She had no symptoms or significant EKG changes during the regadenoson infusion or in the subsequent recovery period. So in terms of the findings of the PET study, the perfusion images demonstrate a small and severe vasodilator-induced reversible perfusion defect in the basal and mid-infralateral segments. And there's also a small and moderate intensity reversible perfusion defect in the mid-anterolateral and apical lateral segments. So when we move on and look at the gated images, and I should mention as well, in fact, there was transient ischemic dilatation with a TID ratio of 1.3. A TID ratio of greater than 1.13 is considered to be significant with rubidium PET. So in terms of the gated imaging, there were in fact matching wall motion abnormalities which were reversible. So there was a reversible wall motion abnormality with hypokinesis at stress in both the basal infralateral segment and the mid-anterolateral segments and apical lateral segments. There was also a drop in left ventricular ejection fraction from 66% at rest to 60% during stress. We would normally expect to find an increase in left ventricular ejection fraction during peak hyperemia of greater than or equal to 5%. And the coronary flow reserve was also found to be abnormal in both the left circumflex and LAD territories, with the coronary flow reserve less than 2 in both of these territories. The right coronary artery coronary flow reserve was normal.
Thank you, Dr. Horgan. That's a very nice explanation of this important perfusion PET study. A couple of questions regarding PET versus SPECT. You noted in this case there's multivessel ischemia. Would you say that's more commonplace in PET than SPECT? And then if so, why?
Yes, I would say that it's more commonly found in PET when compared to SPECT. And it really has to do with the superior diagnostic accuracy of PET. SPECT often only identifies the coronary territory affected by the most severe stenosis. It's felt that the superior diagnostic accuracy of PET is also as a result of the better flow characteristics of rubidium when compared to technetium. So yes, PET is a better tool in terms of differentiating, multivessel disease in comparison to SPECT.
Very good. The second question is this interesting finding of a reduction in ejection fraction as well as reversible wall motion abnormalities in this particular study. Can you comment on differences between SPECT wall motion and PET wall motion during perfusion studies?
Sure. So one of the very nice things about rubidium PET relates to the short half-life of rubidium. The half-life of rubidium is roughly 75 seconds. So what this means in essence is that when we acquire the gated imaging at both stress and rest, it's in effect like real-time imaging. So we're appreciating the wall motion during the period of ischemia, and hence we often find wall motion abnormalities when there is significant ischemia, which are reversible, and this leads to perhaps a reduction in left ventricular ejection fraction. This is something that's not appreciated on SPECT because the stress images, the gated stress images, are actually acquired often 30 to 60 minutes after the dose is administered, and this really has to do with the longer half-life of technetium. So this is a real advantage of PET when compared to SPECT.
So in a sense, it's like getting a stress echo and a stress perfusion study in the same setting.
Precisely, yeah.
This patient obviously has an abnormal studying. So what is the thought process in terms of catheterization?
Yes, I think in light of the patient's symptoms and multiple risk factors and now evidence of multivessel disease on PET myocardial perfusion imaging, the next step is a cardiac catheterization. She did in fact undergo cardiac catheterization, and I can share the results of the catheterization with you. So in terms of her left anterior descending, she has a very large bifurcating first diagonal branch which has severe disease in the proximal course, and this likely explains the perfusion abnormality we found in the mid-anterolateral and apical lateral segments. She also has sequential stenoses in a large second obtuse marginal branch of the left circumflex, which likely explains the basal infralateral abnormality, perfusion abnormality we found on the PET scan. And the additional thing that was actually found on the coronary angiogram is that she has an occluded posterolateral ventricular branch of the right coronary artery, and there's a large collateral branch coming from the left circumflex supplying this territory. So indeed she was found to have multivessel disease, and she subsequently underwent percutaneous intervention with a drug-eluting stent to the sequential stenoses in the large obtuse marginal branch.
So in fact, the PET study very well predicted the findings of at catheterization.
It absolutely, in fact, the identification of the anatomy of the disease was very precise with PET.
That was an excellent explanation of the catheterization results, and it sounds like the PET study very much described the findings at angiography. Could you give us your experience of the correlation between your PET studies and catheterization results at Morristown?
Mm-hmm. Yeah, we're having are finding that there is an excellent correlation between the PET findings and those patients who move forward to have a cardiac catheterization. Really, the accuracy is very reassuring, and more so, I must say, than the experience with SPECT. I think a lot of that has to do with the fact that we're not dealing with attenuation artifacts in the same way at all. It's clear why the sensitivity and specificity of PET is in the region of 90%. When compared to SPECT, which is closer to 80%. So we're really experiencing very good correlation.
Excellent. Let's move on to some questions. I will read the questions and then Dr. Horgan will give the response. Question number one, in terms of detection of multivessel coronary disease, which of the following is false. And question A is, in the presence of multivessel disease, SPECT identifies only the coronary territory affected by the most severe stenosis. Question B is, PET compared with SPECT improves the ability of MPI to recognize the presence of multivessel CAD. Question C, the superior spatial resolution of SPECT compared to PET improves the discrimination of multivessel versus single vessel CAD. And question D, coronary flow reserve improves the sensitivity of PET MPI for the detection of multivessel disease. So we're looking for a false response. Dr. Horgan?
There is one false answer, and that is C. The superior spatial resolution of SPECT compared to PET improves the discrimination of multivessel, single vessel versus single vessel coronary artery disease. That is indeed false. So I'll just begin with the first potential answer. In the presence of multivessel disease, SPECT often identifies only the coronary territory affected by the most severe stenosis. This is indeed true. And, you know, PET, in fact, usually identifies perfusion abnormalities relating to most flow-limiting stenoses, but unfortunately, due to the inferior sensitivity and specificity of SPECT, it often just identifies that, the most severe stenosis. And then in terms of the second potential answer, B, PET compared with SPECT improves the ability of myocardial perfusion imaging to recognize the presence of multivessel coronary artery disease. Well, this is very much true, and it's really as a result of the improved diagnostic accuracy of PET. Also, the additional features of PET compared to SPECT in terms of real-time gated imaging and the addition of coronary flow reserve. These additional aspects to PET provide, more accurate evaluation and help us to tease out multivessel coronary disease. Then the false answer was the superior spatial. Well, we know that SPECT does not have superior spatial resolution when compared to PET. The spatial resolution of PET is largely due to the fact that the superior spatial resolution of PET is largely due to the fact that PET only records coincident events, which pinpoints the source of the photons more accurately than SPECT, and the spatial resolution of PET is roughly 3 millimeters when compared to SPECT, which is 6 millimeters. So this answer is clearly false. And in terms of the final potential answer, coronary flow reserve improves the sensitivity of PET myocardial perfusion imaging for the detection of multivessel disease. Well, that is true. Coronary flow reserve helps to limit the number of false negatives in terms of PET myocardial perfusion imaging, provided, of course, the patient has had an appropriate vasodilatory response.
Thank you, Dr. Horgan. Let's move on to question 2. Which of the following statements is true regarding wall motion evaluation with SPECT and PET? A, reversible wall motion abnormalities are observed more frequently with SPECT compared to PET. B, gated PET imaging provides a unique opportunity to assess LVEF at both rest and stress, as opposed to post-stress with gated SPECT. C, gated SPECT wall motion abnormalities reflect real-time wall motion at peak stress. And finally, D, a high LVEF reserve is not a useful tool to exclude left main or three-vessel coronary artery disease non-invasively. Dr. Horgan?
Yes, so B is indeed the true are the correct answer here. So B is true, A, C, and D are all false. So this is something we touched on a little earlier during this case presentation. So A, wall motion abnormalities are observed more frequently with SPECT compared to PET. Well, this is not true. Again, it comes back to the improved spatial resolution of PET. It comes back to the fact that, we have essentially real-time imaging, both at rest and stress. So wall motion abnormalities are observed more frequently in PET, actually, when compared to SPECT. And then B, as I said, is true. The gated PET imaging provides a unique opportunity to assess LVEF at rest and peak stress. In terms of C, this is a false answer. Regarding SPECT, wall motion abnormalities on the gated stress images reflect real time. Again, we discussed this. This is not real time. It's roughly 30 to 60 minutes post the injection of technetium. So it's real time in PET, but not real time in SPECT. So then the last potential answer, D, well, this is false. A high LVEF reserve is not a useful tool to exclude left main or three-vessel coronary disease non-invasively. So left ventricular ejection fraction reserve is stress ejection fraction minus rest ejection fraction. And in fact, Dorbala et al. Demonstrated in a very nice paper that left ventricular ejection fraction reserve of greater than or equal to 5% has a negative predictive value of 97% in terms of excluding the presence of three-vessel coronary disease or left main coronary disease. So this is another useful tool that we can incorporate into our interpretation of the PET myocardial perfusion imaging study.
Thank you, Dr. Horgan. I think this is an excellent case describing a patient with symptoms of dyspnea undergoing a PET perfusion study which demonstrated multi-vessel ischemia and at catheterization confirming those findings. Now, at Morristown, approximately a year ago, Dr. Horgan and Dr. Seth Uretsky began a cardiac PET program at that institution. I wonder, Dr. Horgan, if you could explain to us the thought process to why the PET program was initiated and whether you consider it to be successful a year later.
Mm-hmm. Well, I'm very fortunate to work in Morristown Medical Center, which is really a leader in, innovation in terms of medicine in the central New Jersey area. Nuclear imaging is something that is undertaken a lot amongst those working in cardiovascular medicine. And one of the concerns was, the attenuation artifacts that were being identified, which were kind of leading to downstream testing. And, as the American Society of Nuclear Cardiology recommends, PET myocardial perfusion imaging is really something that, we need to adopt and will help to limit such attenuation artifacts, providing more accurate testing, but in patients who who are unable to exercise, undergoing vasodilator nuclear imaging. So with that in mind, we undertook to begin a PET program at Morristown Medical Center, which has been, I won't lie, there's been some teething difficulties as you might expect with the commencement of any new program, but I'm happy to report that by and large the cardiology fraternity working out of Morristown Medical Center have embraced the program and are utilizing it effectively. We're moving forward, and our referral base is increasing every month, and the program is definitely growing. As mentioned earlier in the discussion, it really is very clear, in terms of when one is reading PET versus SPECT, the superiority of this modality is very, very clear. I really see it as the nuclear imaging test of choice in the future.